Statins are the go-to treatment for managing high cholesterol, lowering LDL levels and reducing the risk of heart attacks, strokes, and other cardiovascular events.
These medications work by blocking the binding of HMG-CoA to HMG-CoA reductase in the liver. Uninhibited, this enzyme drives the reaction that determines how quickly cholesterol is made. When a statin inhibits this enzyme, less cholesterol is produced. Now, the liver, in an effort to compensate for the now lowered levels of cholesterol, increases its production of the LDL receptor, which then binds to the LDL cholesterol particles in the blood and removes them from the bloodstream, effectively lowering blood LDL levels. The liver also decreases VLDL production, reducing triglycerides and increasing HDL. Statin therapy is categorized based on how much it lowers LDL cholesterol. High-intensity statin therapy can lower LDL by 50% or more. Moderate-intensity statins lower LDL by 30 to 49%, and low-intensity statins lower LDL by less than 30%. High-intensity statins like atorvastatin and rosuvastatin are prescribed to patients with clinical CVD, those with high LDL levels, and high-risk diabetes patients. But they can also be prescribed as moderate-intensity therapy at lower doses. Statins like simvastatin, pravastatin, and fluvastatin are used most often in moderate-intensity therapy for patients who can't tolerate high-intensity therapy or have lower cardiovascular risk, including patients living with diabetes. At lower doses, these statins can also be used in low-intensity statin therapy for patients with the lowest risk of CVD. The most common side effects of statins is myalgia, or muscle pain, which affects between 5% and 10% of patients. These symptoms are usually mild and may be influenced by the nocebo effect, where negative expectations about the medication contribute to perceived side effects. Rarely, statins can cause rhabdomyolysis, a severe condition where muscle cells break down, leading to muscle pain, weakness, and potential kidney damage. This serious side effect is more common in older adults, dehydrated individuals, those who are immunocompromised, or patients taking fibrates or other medications that interact with statins. Other muscle-related side effects include myopathy and myositis, otherwise known as inflammation of the muscle. However, the incidence and severity of these effects can vary among the different statin therapy intensities and medications. Hydrophilic statins like pravastatin, rosuvastatin, and fluvastatin tend to have fewer side effects because they're less permeable and stay in the bloodstream until they reach the liver. Pravastatin, while less potent, is often preferred for its minimal muscle-related side effects and lower risk of drug interactions. Now let's debunk some statin myths. Myth number 1 is that statins cause memory loss. In 2012, a series of flawed studies linked memory loss to statin use, and the United States Food and Drug Administration, or FDA, required statin drug labels to include information about memory loss and cognitive function. Many people worried that lower cholesterol levels might impair brain function. But the brain produces its own cholesterol and does not rely on the cholesterol present in the blood. The studies were poorly designed, lacking many scientific controls needed for validity and often relying on anecdotal evidence and self-reported symptoms. To confirm this association, additional well-designed studies were performed, including large-scale randomized controlled trials and observational studies. But no significant difference in cognitive function between statin users and non-users was ever found. The FDA has since clarified that the potential cognitive effects are rare and reversible when they do occur, and the benefits of statins in reducing cardiovascular events far outweighs the risks. Myth number 2 is that statins increase the risk of diabetes. While statins can slightly raise blood sugar levels, this is mainly a concern for patients with existing prediabetes. For these individuals, a diabetes diagnosis might just confirm a pre-existing condition. Importantly, the cardiovascular benefits of statins far outweigh this slight risk, especially for high-risk patients. Once someone begins or adjusts statin therapy, it's important to check lipid levels within 4 to 12 weeks. And once stable, you should recheck the patient's lipid levels every 3 to 12 months. This allows you to assess how much LDL has been lowered and to check patients' adherence to the medication. Routine liver function tests aren't necessary unless there are symptoms of liver toxicity. Even elevated liver enzymes up to 3 times the normal limit are usually safe, given that statins work on liver cells. So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how Medmastery can help you become a great clinician, make sure to watch the About Medmastery video. So thanks for watching, and I hope to see you again soon.